line of cancer pain management. And in this whole lecture, I'll be covering few important aspects of the cancer pain management. First, what are the mechanism of the cancer pain? How it is different from the other pain management because of the benign issues, benign painful conditions. Second important part is what is called total pain. So this is very important in understanding the cancer pain. Next, I'll be talking about the pharmacotherapy, including the WHO ladder. And last, I'll be talking a little bit about the interventional pain management in cancer pain. So these are the topics, these are the areas which I'll be covering. First, let us ask you, suppose you are seeing a patient of pancreatic cancer and another patient is having the benign pancreatitis or calcific pancreatitis. Both of them are having the abdominal pain. And if I'm asking you this question, that will the management be different? Somebody who is having the pancreatic cancer and having the epigastric abdominal pain, and somebody who is having the chronic pancreatitis, calcific pancreatitis, they are also having the abdominal pain. Are they same, or is there any difference? If there are differences, so what are the differences? So to understand that, so I first will be talking about what are the mechanisms why there are pain in cancer. Number two is how cancer pain is different from the other benign kind of pain. What is called total pain, then outline of the management, and then other things. First of all, let us discuss about what are the mechanisms why there are pain in cancer. So if you're looking about the symptoms, how a cancer can be presented, means what are the first signs and symptoms, or what are the first symptoms why a doctor, why a patient is visiting a doctor and doctor is suspecting that this can be a cancer. So if you're looking about all those symptoms, you can see that the pain is not very important, particularly in the initial part. If you're looking that during the early part of the cancer, how much is the incidence of the pain, and in the late part of the cancer, in the advanced cancer, what are the incidences of the pain, then you can understand that what can be the possible mechanism. So it has been seen in different studies that in the early cancer, pain is the rare symptoms. More commonly, they present with a lump, they present with some bleedings. So these are the few other things which are commoner. Definitely, pain can be one of the symptoms, but pain is rare in the early part of the cancer. Whereas, if you are taking the advanced cancer patient, then you will see that more than 2/3 of these patients are having pain because somehow related with the cancer. So what is the difference between the early stage of the cancer and the late stage of the cancer? The difference is that spreading. The tumor is growing, tumor is pressing on the surrounded areas. So this is the difference. So now with this difference, with this understanding, we can understand that what are the mechanism of the pain in cancer patient. So what are the mechanism? Mechanism is, one is mechanical compression of the nerves, nearby neural tissues. The infiltration of the cancer in the nerve plexus. Or only that if the tumor is growing, then itself can cause without the infiltration of the nerve, even then it can cause the pain. So like in any other kind of pain, what are the classifications? If you can remember my first class on pain pathway, so there we discussed the pain can be broadly divided into nociceptive pain, neuropathic pain. I'm not talking about the nociplastic pain, which is the recently added. Grossly, what is nociceptive pain? The pain because of the non-neural tissue damage is your nociceptive pain. And what is neuropathic pain? Pain because of damage of the neural tissue is responsible for the neuropathic pain. And there is another which is mixed, where the both nociceptive component as well as the neuropathic component both are there. So same thing happens in cancer as well. As I told talking that when the tumor is growing, so it can cause the mechanical pressure, it can cause the sensitize the mechanoreceptors. You can remember how the first part of the pain is transduction. So how there is what is transduction? Transduction is generation of the action potential because of what? Because of the conversion of the energy. What are the energy which is converted into electrical energy or action potentials? It can be mechanical energy, it can be chemical energy, it can be thermal energy, which can be converted into a electrical energy or action potentials. So what happens in cancer? So cancer, it can be a mechanical energy, mechanically pressing, so the receptors might be getting sensitized. It can release some chemicals, which can also cause the sensitizations, and the transduction process might be developing. So the mechanical, the chemical, that means the non-neural tissue damage, because of the expansion, because of the growth of the tumor, there is a possibility of the nociceptive pain. And if I'm talking about how much is the percentage of the nociceptive pain, so it will be exclusive nociceptive pain, maybe 1/3. It is easy to remember like this: 1/3, 1/3, 1/3. 1/3 is exclusively nociceptive pain, 1/3 is exclusively neuropathic pain, and 1/3, rest 1/3 is your mixed kind of pain, mixed nociceptive and neuropathic. So what are the mechanisms of the neuropathic pain in cancer? As I already told you, that there might be the mechanical pressure of the nerve, and there might be the nerve damage. There might be infiltration of the tumor mass into the the nerve plexus. Or another very common is when the patient is receiving chemotherapy or radiotherapy, that can cause the nerve damage, and that can cause the different kinds of neuropathic pain. So cancer pain mechanism, it is not different from the other kind of benign pain. And here also classifications, broad classifications are similar. It can be nociceptive pain, meaning because of non-neural tissue damage, because of the expansion of the tumor mass. Next is neuropathic pain, because of infiltration of the nerves by the tumor tissues, or because of the treatment of the cancer, because of the chemotherapy, because of the radiotherapy. Particularly chemotherapy, there are certain drugs which are more prone to develop the neuropathic pain, and it can be a mixed one. So if there is no difference with the other pain in the mechanism of the cancer pain, then what is the difference? So difference lies somewhere else, and that is called total pain. And it can come as a long question. What is called total pain? And I'll not be telling the name, but I'll be sharing this so that you are not doing the same mistake. So as an examiner in one of the the examinations, where the theory part, there is a long question. In the long question, the question was asked, what is total pain? And majority others answered nicely, correctly. And one candidate answered that total pain means when the pain is there in the starting from the headache, scalp, neck, thorax, upper limb, lower limb. If the pain is there in the whole body, then that is called total pain. So you must not be making the same kind of mistake. This is not total pain. It is the total pain concept is different. So what is the total pain? To come to this total pain, I'll be first discussing about the other component of the pain in cancer. So what happens, when we are talking, when we are declaring that, okay, you are having cancer, what will be the reaction of the patient and the patient's party, patient's family members? Immediately, they're thinking, okay, the death sentence has been written by God. So what happens? Psychologically, they are very, very disturbed. They immediately start crying. The family member starts crying. It is so much emotionally disturbed conditions. So what we learn from the definition of the pain? The pain is an unpleasant sensory and emotional component. So if there are emotional disturbance, then what will happen? The feelings of the pain will be increased. So as soon as the diagnosis is made, and that is the reason there is a ways to break the bad news. How to break a bad news. This is also very important part to understand the cancer pain. You should not be telling suddenly that, okay, or rudely that, okay, you are having the cancer. You are just opening your the biopsy report and talking, okay, you are having the cancer. So that should not be. There is certain ways, techniques how to break the bad news. So you should be gradually sensitizing, so that the mental trauma is much less. So that is how the bad news should be broken. But anyhow, whenever the patient is or the patient's family members is getting this confirmation of the diagnosis that this cancer, so the patient becomes emotionally upset. And then first was your physical pain. Then what component is added? Second component is added is your emotional pain. Then what will happen? The patient and the family members will start asking God, God, what was my mistake? Why it happened to me? My friends, so many people are there roaming around, laughing, playing, doing everything, and it happened to me only. So they are start asking this question to God. And that is another very difficult to answer this question. Why it happened to me? I have not done anything wrong in my life. Still, it happened to me. So this is a question to the God, and very difficult to answer by the spiritual gurus, whether whatever is the the religion, whether it is an Hinduism, whether it's a Christian, the person is a Christian or Muslim, whatever might be, they feel very much disturbed by this question, the spiritual question. Why it happened to me? What was my fault? And this is also adding pain. This is also causing contribution to the pain. And this is spiritual pain. So now what happens? Many of the patient is, having the, running here and there, going for the costly treatment. Nowadays, treatment is costly. If there is no insurance, even then the insurance is not going to cover. So what will happen? The patient is going to sell his house, out of job. So all those things, what is happening? There is very much financial hardship. In India, emotionally, the insurance coverage, only very few percentage have the full insurance coverage. Majority either don't have insurance, or even if the insurance coverage is there, only the very small partial coverage is there. So what is going to happen? The family, the person starts suffering from the financial problem. So another component is added, financial pain, the agony, where from the money will come for this cancer treatment. So this agony, this anxiety also contributes to the pain. That is your financial pain. Then what will happen? Patient is happening, very much disturbed. All the family members are disturbed. They are, maybe sometimes they are out of job. If the patient is in the private companies, maybe out of job, no service, nothing, no coverage. Our Indian scenario is very like that only. So what is going to happen? So financially, very much, and next part, very much ruined. And next part is the other relatives. They are starting, okay, what happened? What happened? And what the family and the patient will be telling? They'll be crying that, okay, cancer happened. And what will be the reaction by the other family members, other relatives? They'll start sympathizing. So this patient who is having the cancer, he will be again further disturbed by the reaction of the other relatives. So this is causing social problem. Socially, they become, they are becoming very much disturbed, financially disturbed, emotionally disturbed, spiritually disturbed. So they are getting socially separated also, because all others start sympathizing, and they feel, why it happened to me? Financially so much burden, and everything is causing the isolation from the other relatives. So this is causing social pain. So understand, the cancer patient, when the cancer is diagnosed, so all the things are coming one by one. So pain is not just physical pain in cancer patient. So all these things contributes in pain, and this is called total pain. So what is total pain in cancer patient? Cancer pain. So total pain is all these different components of the pain. It's not just the physical pain. It is emotional pain. It is spiritual pain. It is social pain. So all these together is what is called total pain in cancer. Right? So now I'll be coming to the next important point. That is how to manage cancer pain. So cancer pain, as we are discussing, and we already know that the cancer patient has the different kinds of component, different types of pain. It can be nociceptive pain, it can be neuropathic pain. There are a lot of other components, emotional components, spiritual components. So it is very tough, very difficult to manage cancer patient. Don't think that I'll be doing a nerve block and the patient will be fantastic, pain-free. You know, cancer pain is very, very, very difficult to manage. Why? I explained you. It can be a combination of the different by mechanism. It will be difficult by because there's so many other components because of the total pain. So cancer pain is always difficult to manage. Still, WHO has tried to simplify it with introduction of WHO ladder in 80s, long back, and still WHO ladder is relevant. Particularly those who are new in cancer pain management, definitely they should follow the WHO ladder. So what is WHO ladder? So WHO ladder says that the cancer pain, so initially when the pain is mild, you should be managing with the non-opioids. Non-opioid means it can be your paracetamol, it can be your NSAIDs. Then if it is not managed by these non-opioids, or if the patient is having the moderate to severe pain, then you should be adding mild, weak opioid like tramadol, tapentadol, codeine, these kinds of weak opioid with or without non-opioid. This is your second step. And third step is when the pain is too severe, when the pain is not managed by the first two steps, then you should be thinking of strong opioids like morphine, fentanyl, and your right now buprenorphine. These are the three strong opioids which are available in the Indian market. So one of the very important question is asked: should we go step by step? Should we go fast with the paracetamol or non-opioids, then going to the second step, then going to the third step? Or we can jump the steps, like in the first steps, third step, somebody having the very severe pain, can you go directly with the morphine? Answer is yes. So it is step doesn't mean that initially the steps was explained like that. That always starting the first step, then going to go to the second step, then go to the third step. So it's not like that. If you feel the pain is too severe, you can go jump directly into the morphine. There is no need of trying first non-opioids, then opioid, mild opioids, then going to the strong opioid. No. If you feel that pain is too severe, you can straight away go to the morphine. So the steps doesn't mean that you have to climb the steps one by one. No. Second important part of this WHO ladder is you can add adjuvant drug at any steps whenever you feel. Whenever you feel means when to add adjuvant drug? Adjuvant drug means co-analgesic. And what are the indications of the co-analgesics? Analgesics are for, this is a very rough rule. Exceptions of rule are always there. If the patient is having the nociceptive pain, then the treatment should be with analgesics. Analgesic means paracetamol, NSAIDs, non-steroidal anti-inflammatory drug, and opioids. These are called analgesics. So if the pain is nociceptive, the treatment should be done with analgesics. And if the patient is having the neuropathic pain, then analgesic has any role? Answer is no. Suppose somebody, I give this example, classical example, somebody is having the trigeminal neuralgia. Will you prescribe a diclofenac sodium? Will you prescribe a paracetamol? Answer is no. You'll straight start what? Carbamazepine. Take that out. So if the patient is having the neuropathic pain, then the drug of choice is your co-analgesic. Co-analgesic means, or adjuvants, means anticonvulsants, antidepressants, sodium channel blockers. So all these different muscle laxants. These are the co-analgesics. They themselves are not analgesics. They are not non-steroidal anti-inflammatory drug. They are not opioids. They are not paracetamol. But still, they manage pain, and that is the reason why they are called co-analgesics. So co-analgesics or adjuvant drug are the treatment of choice when the pain is neuropathic. We know all this from the management of the benign pain. So same thing is applicable here as well. That means if you feel that the pain is neuropathic, you should be adding adjuvant drug. Adjuvant drug means it can be anticonvulsants like amitriptyline, like duloxetine. It can be anticonvulsant like your gabapentin, pregabalin. So these are the drugs you should be adding at any steps. Or if you think that it's a pure neuropathic pain, then you can go ahead only with this without having the other opioids. So it depends. That means you have to understand whether this pain is pure nociceptive or neuropathic or a combination. Depending on that, you should be choosing your drug, what kind of drug should be used. So WHO ladder, first step is paracetamol and non-opioids. Next step is paracetamol or NSAIDs plus minus with or without co-analgesic or adjuvant drugs. And third step is strong opioids. And at any of this step, you can add adjuvant or anticonvulsant depending on having your diagnosis, whether the patient is having the neuropathic pain component or not. Okay, then where is the role of interventional pain management? So interventional pain management, initially it was not there in the WHO ladder. But then it was suggested that it can be added as a fourth step. So fourth step of WHO ladder is your interventional pain management. So you can do an R block like celiac plexus block, suprahepatic gastric plexus block, today how to be demonstrated. So this can be added later on based on your management plan. But again, if it is asked, should we first try the first step, second step, third step, then we should be going to the fourth step? Answer is no. Answer is depending on the individual patient, tailored management should be planned. And that tailor-made management depends on your wisdom. Means you can straight away, like what you told, you can straight away go to the second step, you can straight away go to the third step. Same way, you can straight away go to the fourth step. Without trying the first step, second step, third step, you can straight away go to the fourth step. That means you can straight away go to the interventional pain management. And there are studies, recent studies, which are telling that in certain pain, cancer pain, the interventional pain management is much better than the conservative management, oral pharmacological management. Like the most maximum number of publications, randomized trials are there in favor of celiac plexus block in pancreatic cancer. And what are these trials? These trials are the pancreatic cancer patients, two groups, one group managed with morphine and other by WHO ladder, and another group straight away into the celiac plexus block. And you know what is the result? Result is quality of the life, amount of the pain relief, and even survival is longer if these patients are managed with the celiac plexus block from the beginning, without giving any trial on the opioids, non-opioids, morphine, without giving any of these trials, straight away jumping to the fourth step, that means interventional pain management, the results are much better. That means if you are receiving a cancer pain patient who is having the pancreatic cancer or upper abdominal or in the lower abdominal, particularly the abdominal cancer patient, pain management is better if we are if we are doing the interventional pain management at the beginning without having a trial of the other drugs. So this is your WHO ladder, and this is where the interventional pain management is incorporated in our management. Now I'll be talking a little bit about the pharmacotherapy, particularly I'll be talking about the morphine. So other things already pharmacotherapy class has been taken. I'll be talking a little bit about the morphine because this is one of the very basic areas where all of us should know, must know, what are the initial doses of the morphine, what is the maximum dose of the morphine, how to escalate the dose of the morphine, what are the common side effects, and how this side effects of the morphine can be taken care. What is called opioid rotation, what is called breakthrough pain, what is called incidental pain. So these are the few certain things which is related with the pharmacological management of the cancer patient. So now let us first start with what is the morphine. As I told initially, also we have discussed that morphine is a pure mu agonist, and that is the reason why morphine don't have any ceiling effect. So many times I ask this question, that what is the maximum dose of morphine? Like if I'm asking, what is the maximum dose of gabapentin? What is the answer? 3,600 is the maximum dose of gabapentin. So dose range is from 900 to 3,600 for gabapentin. Same way, if I'm asking what is the dose of the maximum dose of the pregabalin, maximum dose of the the carbamazepine, almost all drugs have their maximum dose that it should not be exceeding that dose limit. But what is the dose limit for the morphine? What is the maximum dose you can use? Answer is you can use any dose. There is no upper limit. No upper limit. You can use tons if needed. But definitely there are ways to start this. So how to start? What is the starting dose? Starting dose, again, remember it very nicely. I have seen so many prescriptions. Morphine, 1 tablet, half tablet, twice a day. Don't prescribe in that way. I've seen many patients, many prescriptions I have seen mostly written by the general physicians or other physicians. Morphine 10 milligram twice a day. Never. No, you should know how to start morphine. So what is the standard dose of morphine? Morphine starting dose in normal ordinary body weight, 60 milligram per day. This is the standard starting dose. 60 milligram per day. Don't forget it. 60 milligram per day is the starting dose of morphine, provided they don't have the other comorbidity. So what are the comorbidities? And what happens if the patient is having the comorbidities? Comorbidity means if the patient is cachectic because of the cancer, patient is unable to eat nicely, or the patient is having the other problems. So patient is cachectic, body weight is less than 50 kg, sorry. Or if the patient is elderly, more than 65 years of age, or the patient is having the the other problems. Other problems means if the patient is having the kidney disease, liver disease, or other very severe disease. So in those situations, you should be making the starting dose half than the normal, that is 30 milligram. But if these comorbidities are not there, then the starting dose is 60 milligram per day. So how to use it? 20 milligram 3 times a day or 30 milligram twice a day? Answer is no. First, you should be starting with plain morphine. Okay, this is also another very question. So what is the duration of action of the morphine? So how frequently it should be given depends on the duration of action. So if you're using plain morphine, the duration of action is 4 hours. 4 hours. That means the one dose to second dose, the dose gap should be 4 hours. So morphine tablet should be given every 4 hours. So 10 milligram every 4 hours. So if you're starting at the morning 6 a.m. first dose, so 6, 10, 2 p.m., 6 p.m., 10 p.m., then at midnight 2 a.m. Answer is no. So what should be done that time? You should be given double dose, 20 milligram at bedtime at 10. And then again, next dose should be starting at 6. And that is why it is called the morphine should be given by the clock. By the clock. Every 4 hourly. Only at night, you should give the double dose. That means you have to give 5 times. Every 4 hourly. At night, the double dose. And next day morning, you again starting the same. So morphine, how to administer? It should be at best route of administration is oral. So by the mouth, by the clock, these are talked about the morphine. So you should be giving most preferable route is your oral, and always should be given. It's not SOS. Take 10 milligram SOS. No. That kind of prescription is a very bad prescription. Morphine must be given by the clock. 6, like I have given the example, every 4 hourly and at night double dose. And if the patient is cachectic or other comorbidities or elderly, then you have to make 5 milligram. 5 milligram tablet is not available. 10 milligram tablet, plain tablet is available. So make it half tablet, 10 milligram, half tablet, every 4 hourly, at night 1 tablet. This is how morphine should be started. Okay. And now you see that the patient's pain relief is there, then you should be converting into a sustained release tablet. So sustained release tablet, there are 2 types of sustained release tablet. 12 hourly, it is more commonly available, or 24 hourly. So then once you know that the patient's total daily dose is 60 milligram, then you give 30 milligram tablet in the morning at 6 a.m. and 30 milligram sustained release tablet at the 6 p.m. So that should be given. But first you have to titrate the dose to understand what is the dose requirement. Dose requirement varies from person to person. Now suppose you are getting a patient, you have started with the 60 milligram dose and the patient is telling, no, my pain is not that much reduced. So question is, what is the goal? Suppose somebody is having the pain 8 out of 10. What should be the goal? Should we go to the 0 out of 10? Answer is no. It should be reduced to a very minimal tolerable limit. Our aim should be 1 out of 10 or 2 out of 10, not 0 out of 10. Why? Because there are a long list of side effects of morphine. What are the side effects of morphine? The most common, you must not forget, is your constipation. So that is the reason why whenever you are writing morphine, you must be writing a purgative. Otherwise, that is another very bad. So you must not be forgetting a purgative along with morphine. Always, 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 always write and purgative. So morphine and other just I'm talking about the side effects of the morphine. So constipation, your nausea, vomiting. Many patients suffer from the nausea, vomiting. Nausea, vomiting is not always. So you need not be given a the ondansetron or other kind of anti-nauseating drug all the time. But if the patient is complaining, you must be writing it. So one is constipation, another is nausea, vomiting. I'm talking about the common side effects. Then is itching. Many times you'll be getting the itching. But what is the most dreadful complications? All doctors are afraid of it. That is a respiratory depression, isn't it? But remember, respiratory depression, what is the antidote? Antidote is pain. So first, pain will be 0, and then there will be respiratory depression. So if you are aiming, your goal of pain relief is to make pain from 8 to 1, then there will be no respiratory depression. So very minimal tolerable pain should be there. That should be your goal. And as I was telling, how to titrate the dose. So initially given 60 milligram per day dose, and patient is telling, okay, my pain is not relief. Maybe from 8 it is now 6. Then you have to escalate the dose. So normally how much to escalate? Around 30%. When to escalate? Normally around 3 to 7 days. You just wait for a few days, and then the pain is not relief, you can escalate it. As I told you, escalation, there is no upper limit. So you first try with the 60 milligram, then after a few days, you might be increasing to 90 milligram, 120 milligram. So gradually, you try to understand what is the dose needed for this patient, and then you convert that into a sustained release tablet. So this is how morphine should be given. And what will happen after some time? Suppose patient is having the very good relief with the 60 milligram. After 6 months, will the same dose will be giving the same relief? Answer is no. So after some time, the same dose will not be giving the good pain relief to this patient. So this is the time to increase your dose. So increase by 30%. Again, after some time when the pain will be increasing, again increase by 30%. So in that way, you can increase to any limit. Many times we call it sky is the limit. But for the morphine, even sky is not the limit. You can go beyond the sky also. There is no upper limit for morphine, remember it. No upper limit for the fentanyl also. If you're asking what is the upper limit of the fentanyl, you can go on escalating whatever is the whatever it is. But first you have to understand that this drug is giving relief. If there is no relief, there is no, it is meaningless to give to increase the dose. First you try to understand whether escalate the dose, see how much relief is there. Now relief is there, but after some time pain is again coming back, then you increase the dose. So that is the way you have to do. But suppose patient is having completely neuropathic pain, some nerve is pressed and the pain is there. So will the morphine is going to help? The answer is no. So their morphine is not the answer. So you have to add some co-analgesic. That is a different issue. There you must not be increasing the dose much. But I'm talking when there is partial relief or full relief, after some time the pain is again increasing. This is the time to increase and go on increasing skies. That sky, no, actually it's not sky, beyond sky. You can increase to any limit. There is no upper dose, no ceiling effect of morphine or fentanyl. Now, very important part is your two terms I will be discussing. One term is what is called opioid rotation. So what is opioid rotation? So suppose you are giving the dose, after some time it is increasing, again you are increasing the dose. So if we by that time, without increasing the dose by 30%, that what is told, what is the standard treatment, you can rotate to the another opioid of the same equipotent dose. So you have to have a chart of the equipotent dose. Difficult to manage, remember all the times. But as a whole, the 90 milligram morphine is equivalent to 25 microgram per hour release fentanyl patch. So you can switch over to the fentanyl patch. Fentanyl patch are available 12.5 microgram per hour release. So patch is your fentanyl patch is how much per hour is released. So 12.5 microgram per hour release, 25 microgram, 37.5, 50, 75. So these are the different kinds of patches available. So 90 milligram morphine daily dose is equivalent to 25 microgram per hour release fentanyl patch. So accordingly, you calculate your dose, the fentanyl, switch to the fentanyl, or you can switch over to the buprenorphine also. So buprenorphine also similar. 90 milligram of the morphine is equivalent to your 10 microgram per hour, the release of the buprenorphine. So you can switch over to the buprenorphine also. So and that way, you go on rotating, and that might be helping you not to go for the escalation of the dose. But still, if needed, you can go on escalation, and there is no upper limit, I told you. So this is called opioid rotation. That means instead of increasing the dose, you can rotate to the other equipotent dose so that your need of escalating the dose will be minimized. And that is why opioid rotation is beneficial to those, particularly those patients where dose is increasing requirement very soon. Another important term very frequently used is your breakthrough pain. What is called breakthrough pain in cancer patient? So breakthrough pain is, suppose you are giving, as I told you, 60 milligram your calculated dose, and you are giving 30 milligram in the morning sustained release tablet, 30 milligram in the evening sustained release tablet. Patient is very happy, pain relief is there. And now after 2 to 3 months, patient is telling mornings 6 a.m. one tablet, evening 6 p.m. is one tablet, but at 5 p.m. patient is telling, okay, no, my pain has started. So this is called breakthrough pain. So breakthrough pain is also called end of the dose failure. That means our curve is not goes to a straight line, like 6 a.m. and 6 p.m. It's not like that. It's like that. So when the blood concentration is reduced, pain might be reappearing. That is called breakthrough pain. So how the breakthrough pain should be managed? Breakthrough pain should be managed with additional plain morphine. So suppose 30 milligram in the morning, 30 milligram in the evening, 5 p.m. pain is coming back. Ask the patient to take additional 10 milligram morphine. And then you gradually, so same way, 5 a.m. in the morning, patient will be having pain, take another 10 milligram. That means now the patient's dose requirement is 40 milligram twice a day. So now what we'll do, after a few days, if you see that the almost daily patient is having breakthrough pain, and patient is needing an additional 10 milligram of morphine in the evening and 10 milligram in the morning, that means patient's daily dose requirement has increased to 80 milligram, not 60 milligram is not enough. So what you need to do, you go to change either 30 milligram and 10 milligram morphine are there in the morning, 40 at night 40, or you can go straight away to the the 90 milligram. That means depending on the dosage schedule, you can make it 90 milligram or 80 milligram per day. So this is called breakthrough pain. Breakthrough pain is because of end of the dose failure. Another pain is called incidental pain. Incidental pain means suddenly patient was fine, but as soon as the patient is trying to stand or sit, suppose somebody is having the multiple compression fracture, patient is fine when the patient is lying down, but as soon as the patient is sitting, movement, patient pain. That is called incidental pain. So these are the very, very important topics, terms used in cancer pain. One, I told you, total pain. It can come as a long question. What is called the breakthrough pain, what is called opioid rotation, what is called incidental pain. So all these terminologies should be very clear to you. So next,
at certain kind of cancer, the interventional pain management is the first choice. As I told you, in the most of the abdominal malignancy, interventional management is the first choice. But in the other cases as well, suppose somebody is having a widespread pain, you can try definitely morphine or other things. But again, there you can think of the intrathecal morphine at the beginning. As I told, there is no certain rule that you should be using interventional pain management only after you have tried all those first step, second step, third step. You can go to the interventional pain management at the beginning, jumping to the fourth step itself. Like other steps in the WHO ladder, there is no need to climb up the steps. You can jump into the step directly. So same way, interventional pain management. What are the advantage and disadvantage of the interventional management? Advantage is, once you are doing it, patient, there is no side effects of the pharmacotherapy. This is one of the very important. And another important reason related to this, that the many times morphine availability is a question. So if you are doing an interventions, at least for several months, patient don't need any pharmacotherapy, or even the pharmacotherapy is needed, very drug requirement will be very much minimized. So that is one of the very important, advantage of giving the, the interventional management, particularly the neurolytic blocks. The neurolytic blocks is having another important advantage, that once you are doing it, then long-term pain relief will be there. And overall cost, if you're adding all the cost of the pharmacotherapy versus the interventional management, the interventional management might be the less costly if you're adding all the cost of the pharmacotherapy. But what are the disadvantage? There must be a good trained doctor who can do these interventions, good setup to do these interventions. And initial cost may be slightly higher than the pharmacotherapy. So these are the advantage and disadvantage. Most important indication for the interventional management is what? That the pain must be localized. When the pain is widespread, then only intervention which is available is intrathecal pump. Otherwise, if the pain is well localized, and particularly in the abdominal cancers, the interventional management is having very, very important role.